bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. We would also like to thank Prolacta Bioscience for supporting our webinar program. Prolacta is a life sciences company dedicated to improving quality of life by advancing the science of human milk and providing specialty formulations made exclusively from human milk for the nutritional needs of premature infants in the NICU. Prolacta has been a supporter of the CAFC conference for the last couple of years, and we look forward to welcoming them and their colleagues back to the 2015 CAFC annual conference in Quebec City, where they'll be hosting a lunch session on the importance of human milk for premature infants in the NICU. Welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. Today's webinar is titled Challenges in Remote Air Medical Transport, and we're very excited to bring a great panel today that is prepared to share what I think will be some very interesting stories, as well as to share their experiences of performing care of children in the remote north and a lot of the challenges that go along with that. This session comes to us from our Interfacility Transport Committee, so it's great to showcase some of that work, and we're going to hear from the co-chair of that committee, one of the co-chairs of that committee, Kate Mann, who's going to join us in just a second. But before we do that, one more thing before I introduce the panel, I'd like to mention the 2015 CAFC Annual Conference, which is coming up on October 18th to the 20th. And everyone is invited to join us in Quebec City, where we will learn and share the expertise from across the child and youth healthcare community and finding solutions in children's healthcare. So we hope everyone joins us there, and you can always find more information by going to the conference website at conference.cafc.org. And we do have the early bird registration is on right now, but that's closing on August 22nd. So please do take advantage of that. All right, so it's my pleasure to introduce the panelists who will be presenting. We have four colleagues from across the north. First, we'll have Penny Triggs, who's a registered nurse with 10 years of critical care experience and over 28 years of experience in air medical transport, including 6 years with the Manitoba Government Air Ambulance and 22 years with Keewatin Air. Joining Penny is Cara Livy, who's a nurse practitioner with Advanced Medical Solutions and Medic North as their VP of Operations for the Air Medical Program. She has many years of experience as a flight nurse in the Arctic and as a practitioner in the NICU. And she now extending that expertise in the western part of Nunavut and the Northwest Territories. And then we'll have Sheila Thompson, who is an RN with critical care experience as a flight nurse and manager in air ambulance operations and multiple years as an RN in the outpost environment. She's currently the manager of program design and implementation in the Disability Management Unit of the Public Service Commission for the Government of the Yukon. And we also have Dr. Sandy MacDonald, who is the Senior Chief of Staff for the Government of Nunavut, and is a family practitioner and GP anesthetist in Iqaluit. Dr. MacDonald has extensive knowledge of the healthcare system in Nunavut, visiting the communities regularly, and is the chief liaison between the air ambulance providers and the government of Nunavut. So a great panel today. And before we get on to our panel, I'm going to hand the virtual podium over to Kate Mann, who is, as I mentioned, one of the co-chairs of CAFC's Interfacility Transport Committee. So over to you, Kate.
Well, thank you, Doug, and welcome to everyone joining us across the country and perhaps beyond the borders of Canada at the moment. It's my pleasure to be part of the panel today. I am one of two co-chairs. My other co-chair is Dr. Alan DeCan, who is a pediatric intensivist and director of the Air Medical Transport Program in Edmonton at Stollery Children's. He is traveling somewhere, I believe in the United States today, and won't be able to join us. Just a little on my background. I am an RN and worked at the IWK Health Center in Halifax for almost 30 years, and most of that time was both at the bedside in critical care, PICU, and then into management, where one of my responsibilities as director was our care program, which included air medical transport in our partnership with EHS Lifelight here in Nova Scotia, which is the provider of our air medical transport services. So I am left the IWK and semi-retired at the moment, and but my beginnings with this committee was back in 2008 in Edmonton at a CAPC conference, and there was a presentation on the challenges of doing pediatric and neonatal transport, as well as a discussion a bit about obstetrics. And so from about maybe 30 to 50 people in that room, it became obvious that we needed to have a Canadian group put together to really start to look at the development of national standards for air medical transport for the safe transport of pediatric, neonates, and high-risk obstetrical patients. So that was 7 years ago, and I have to say that our group has, started in that room and evolved over time. Some people have been with it from the beginning, and others have come and gone as their lives have changed, and we've had lots of new people join us. So we are certainly open to having people join our Transport Steering Committee. The thing that really strikes me as I look back at the work that we've been doing since 2008 was the conversations that happened as we got together as practitioners across the country, sharing our experience. And as I was saying just before we started this call, the thing that really struck me was also there was never any sense of being territorial about what we wanted to share with each other. It has always been very open in the united goal, I guess, to provide the best care possible to children, women, and neonates. With that in mind, we have done a lot of work, and I am happy to say that, and it is housed on the Knowledge Exchange Network, CAN as it's called with CAPC. We have made visible practitioner profile is what we call it. These are competencies and skills that we have put together as a group of minds looking at, well, what if you're in the business of air medical transport, what is it that you need to know? And we made a point of not being prescriptive on team configuration, understanding that local challenges, local resources influenced the makeup of teams. So we were never prescriptive on who should be on the team, but rather what kind of knowledge they needed and what kind of skills they needed if they were in the business of air medical transport. So that was one of our first documents, and if you've never seen it, I would encourage you to go to Ken and really have a good look at that work. It's there to be used. From that document, we also looked at system design and had lengthy conversations over the last few years, and it brought us to believing that we needed to put together and partner with Accreditation Canada to develop national standards under Accreditation Canada's Cumentum program. And I am really happy to say that several of us are on that committee in terms of the steering committee that Accreditation Canada puts together to develop their standards according to their processes. And, in less than a year from our first meeting, it was in August last year, we have described the pilot standards and pilot system, and it is looking like we will be ready within the next very short period of time to release those more broadly. They are out for national consultation now, and the group that has been putting those together and reviewing them are looking forward to the feedback that we receive from many of you who have a lot of that kind of experience to look at them and say, do these make sense? Our goal was to really have a Canadian alternative for programs to look at their receiving accreditation. And we think that we're almost there. We believe that we will be there very, very shortly. So developing national standards was driving us from the beginning, and the other part of what we're doing is knowledge translation strategy. Today is one of those initiatives to look at how do we share and spread what is happening across the country, not just the work of what is happening through CAFC, but the work that is happening in everyone's program so that we can learn from each other and know who to talk to in this business. So that is a very brief overview of why we came together and where we are today. So again, I welcome all, and I will hand it back to you, Doug.
And we can see Penny's presentation is up, so now we're going to hand over to Penny Triggs, also a member of CAFC's Interfacility Transport Committee. Over to you, Penny.
Thank you, Doug, and thanks, Kate, very much for the opportunity to give this session. And I'd like to thank Dr. McDonald, Cara Livy, and Sheila Thompson also for their great presentations. I'm looking forward to seeing them myself. What we had really hoped to accomplish in doing this presentation was to provide people that have worked in the North the opportunity to nod their heads and say, yeah, I've been there and done that, and also to provide folks that haven't had the experience some insights into what a patient and what the healthcare provider goes through to move someone from the high Arctic or from the northern parts of a province down to a tertiary center in a big center like Winnipeg or Vancouver or wherever we're going. And I think, that'll be a really interesting perspective for people who haven't got any experience or familiarity with the North. And also I think that we'll also learn a lot about the differences between the three northern Canadian territories. My first 11 and a half years were spent in a tertiary hospital at the Health Science Centre in Winnipeg as a nurse. And I worked almost 10 of those in critical care. So I was cocooned in that protective environment where we saw the sickest of the sick, but we had a lot of resources to call on from specialists and dietitians and clinical pharmacists and nurses and respiratory therapists and, everybody that could possibly join in and help us. And I received patients from the North, from northern Manitoba, Northwest Ontario, and Nunavut, and in all honesty, I probably rolled my eyes occasionally at things that I thought should have been done but weren't, and had very little perspective or appreciation of what kind of effort it takes to move someone 1,000 miles out of the Arctic down to a tertiary center in Winnipeg or wherever they might be going. In 1987, I moved into that realm. I became part of the Manitoba Government Area Program, and I left my cocoon at the Health Sciences Centre. And my eyes were pretty much opened in the first couple of months there. So, 4 weeks before, I had been rolling my eyes when someone came in through the doors and perhaps didn't look pristine. And now people were rolling their eyes when I brought a patient into the emerge or the ICU because all of a sudden reality had struck and I was doing the transports and it wasn't possible to have the patient in the state that they would have been had they been in the ICU. I wanted to talk to you a little bit about an experience I had in my early days of flight nursing, just to give you the perspective of the northern experience. This was 1987, so it's a long time ago, but it's one of the things that stuck in my head. I've got 50 more stories, but this is kind of one of the first ones that I was exposed to. I was on duty as the flight nurse, and I got a call on a Saturday morning from a nursing station in the northern parts of Manitoba about a patient that had suffered a cardiac arrest. And this fellow was being resuscitated at the time. And normally we actually respond to cardiac arrest patients, mainly because these folks we were hours away by flight, and they needed to be resuscitated. And then if there was a successful resuscitation, we'd go to get them. We would provide support and advice and that sort of thing. But this was an unusual circumstance. This young man, who was about 31, had been in the health center on several occasions with atypical sort of lots of gas and upper GI symptoms, and they had not anticipated this was a cardiac event. So he had been treated with everything from pink ladies and antibiotics for a chest infection and not treated for a cardiac problem. So when he came in on the fourth visit and suffered an arrest, you can imagine the emotions that went on, and the physician on call, who happened to be in Winnipeg, was called by the nurses in the community some basic advice was given, and the physician said, I will come up, call the Manitoba Air Ambulance, I'll be there in 20 minutes, and I'll come up and help you guys out. So that was the situation, and it was agreed that we would go and see what we could do to help them out in this situation. So I got the airplane already, the pilots did the flight planning, the physician arrived fairly quickly, and off we went. And of course it was an hour flight to get to that community, so it wasn't like we were, around the corner. But on the way we were able to plan for the transport. And some of the things that kind of came to mind were, this is a health center, not a hospital. So the equipment and supplies they had available to them, and in 1987, that was a long time ago, they even had less than they do now, included they didn't have a monitor defibrillator. They didn't have advanced airway equipment. They had limited resources in general. So what they were able to do is run a 12-lead EKG, reams of paper to get the rhythm, do an oral airway and do BVM ventilation, CPR, and establish an IV and give epinephrine and whatever other medications might be indicated. So that was what was going on in the health center, and I knew I would have to bring in with me everything that would be required to resuscitate and take care of this patient should he be resuscitated at the end of the transport. The other thing is that there were no ambulances in the community, and that remains the case in many communities in the north. So when you go in to get the patient, you're in any number of vehicles, but usually a closed-in van or SUV, or in some communities it's a boat or a hovercraft or a skidoo with a sleigh in the back of it. And you have to be able to have the equipment supplies with you to manage the patient in the health center without relying on their supplies, and then to move the patient out back to the airplane, which means you need to have portable suction, oxygen, monitors, IV fluids, airway management equipment, and everything in between. So there's a lot of planning required in order to accomplish that type of transport. So we discussed our plan, and we both were aware that it was very unlikely that this would be a successful outcome with this poor fellow, but we'd go and do our best. And on arrival, about an hour later, we were met at the airport by a lady driving a van, and we loaded all our gear into her van, and off we went to the health center. When we got there, you can imagine the scene at the health center. The whole community was there. This is a small community. Everybody knows everybody. And so everyone was at the community, and everybody was very, very upset. We went in to see the patient. Obviously, he was being resuscitated at the time. We did some basic assessment and intubated him and did a few things, discussed the situation with the nurses, and everyone agreed that there was no point in carrying on. He had been asystolic for some period of time. And as a result, the physician went out to have a chat with the family and speak to them about what was going on, and then resuscitation was stopped. So that that side of it was fairly straightforward if you get rid of all the emotion of the situation. So you can imagine, first of all, so many people are there, so there's a certain degree of chaos just because of the crowd. The family is very upset and angry because they feel that this fellow's diagnosis was missed, and the nurses are very upset because they feel badly about what's happened. So the whole thing is a difficult thing. In the meantime, I got a call to go on another medevac. So the physician and I had a discussion. He elected to stay in the community and help them work through this challenging situation, and it was up to me and the pilots who had come in with us to pack everything up and get back to the airport. And so we did. We packed everything up, got it in the van, and we headed off with the lady driving us back to the airport. And about halfway there, and this is about a 6-mile drive, on a very desolate little gravel road in the middle of the forest. It's winter time. It's about -25, probably a little blustery. It's not a blizzard, but it's blowing snow. And all of a sudden, we hear some funny sputtering, clunking noises, and the van died. Now, this is before the day of a cell phone, but at the same time, cell phones would probably not work anyway, even at this date. And we have no way of contacting everyone that we are dead on the road. The lady that's driving was very flustered and upset, and the pilot suggested he pop the hood and have a look and see if there was anything obvious that he could fix. But in the meantime, he pops the hood, and she was so stressed by the situation, she suddenly disappeared, and we saw her head off in the ditch and up into the trees, and she was gone. So there we are with $50,000 worth of medevac equipment, sitting in a dead vehicle, probably about 3 miles from the airport where our $4.5 million airplane sits, and we're stuck. So we thought, well, maybe she's going to go and get help, and we waited for a little while, but it was getting colder, it was getting late in the day, and it was getting dark. So we decided that we would have to walk. We have an air ambulance trip waiting for us. So we took off walking, carrying our $50,000 worth of equipment down this little isolated little road in the middle of nowhere. And fortunately, about 10 minutes later, a truck came by, a half-ton truck, and the lady stopped and said that she'd be glad to give us a ride. Unfortunately, the cab was filled with kids, and so we had to load everything into the box of the truck. And we balanced our stretcher with all the equipment on the top of a 45-gallon barrel of oil that was rolling back and forth in the box of the truck. And there was me, 2 pilots, and all our $50,000 worth of medevac equipment in the back of this truck, and she was driving very fast. It felt like 200 miles an hour, but I'm sure it wasn't. And it was very, very cold. And we all looked at each other and laughed hysterically. And I think that, we made it back to the airport. We thawed things out. I had a lot of drugs that I was trying to keep under my parka from freezing. And we had a real good laugh about it. And it really exemplifies the challenges of the North, all the different things that you have to plan for, and all the different things that can happen with no planning even possible to think about that. But you've got to be able to make a decision and choose options that aren't ideal and be adaptable. And you also have to have a great sense of humor, or else you won't last very long. So anybody that has worked in the North probably has many different stories similar to that they can relate to this. There are a lot of differences operating in the North, and I'm just going to quickly go through some of them because I think each of the areas are going to be more specific about what's very unique about Nunavut versus the Yukon versus the Northwest Territories. The first obvious one is distances, and we have a very large landmass up in the 3 territories, and for the most part, specialty services are not located up there. So in order to access those specialty services, the patients have to be moved either from Whitehorse, Yellowknife, Iqaluit, or the smaller communities that are spread out amongst the territories down to southern referral centers. And so a lot of the people are traveling well over 1,000 miles to access care. So that's the first thing. It's just the distances are hard to wrap your head around. And the population is very sparsely spread out. If you think about the fact that Canada has a population of about 36 million or just under 36 million, and a land mass of about just under 10 million square kilometers, it is a huge country, but 37% of that is in the 3 territories. So 37% of the land mass of Canada is up there, and 1/3 of 1% of the population. So just to think about how we provide for the Canada Health Act, which says that regardless of financial or geographic circumstances, everyone's entitled to some basic health care, then we have a big challenge to try to provide that. The other thing that we have to remember is the access to medical resources is very limited. We have 3 regional hospitals, 1 in each of the territories, that can provide some pretty spectacular care, especially when you consider where they're located. But at the same time, specialty services are not available up there. There's no neurosurgeon. There's no neonatal transport team based in Iqaluit. There's, those types of high-risk pediatric, neonatal, and high-risk maternal programs are not available, or other specialty services either. So it is quite challenging to make that available to the patient that's living in Grise Fjord, which is the most northerly community in Canada, and it's 930-some miles north of Iqaluit. That person has a long ways to travel in order to access that kind of care. In terms of normal pathways of referral, I've got some very basic diagrams on this map, and I'm sure the individual territories will talk a little bit more about these referral patterns. But you can see that in the Yukon, the little communities would probably make it into Whitehorse, and the good news in the Yukon is there's roads, so that a lot of them will be able to travel by road access. And then if they can't obtain the care they need in Whitehorse, they'd be referred south, possibly to Edmonton, commonly to Vancouver. So again, a long ways to get access to specialty care. A neonatal team from Vancouver might be able to go up and meet you in Whitehorse, and transport your babies out of Whitehorse. But if you're born in Old Crow or another community in the Yukon, it's probably the air ambulance provider from the region that's going to get them at least as far as Whitehorse. In the Northwest Territories, again, we have a bigger hospital in Yellowknife, and if it can't handle the patients that are referred into Yellowknife, then they'll be forwarded on to Edmonton. And in Nunavut, because it's a big territory that's quite wide, it actually has 3 regions of healthcare services that each are funneled to a different referral center. So in the Western Arctic, which is the Kitikmeot region, the communities are serviced either by Yellowknife or, when none available, to get the care in Yellowknife, off to Edmonton. In the Central Arctic, which is the Kivalliq region, the patients would tend to go to Winnipeg. And in the Eastern Arctic, which is serviced largely by the hospital in Iqaluit, those patients, if they can't be accommodated in Iqaluit, we usually go to Ottawa. So you can see that there's enormous challenges getting the patient from a remote community into the regional hospital, but then they often have to travel forward from there to a referral center in the south. I sort of said this before, but the lack of scene response resources in many of the communities is quite remarkable. And although some of the places that do have ground transport have ambulance services, they're often volunteer services, so the level of care available might be different than what we see down here, where we have formal services that are paid. And of course, but God bless them for doing it, that's for sure. And there are many, many communities where there is no such thing as ambulance services, and therefore it's local people that are driving vans or vehicles of different types, or in northern Manitoba, hovercraft and boats and things like that. So the lack of EMS services also complicates the picture. The other thing that you can't deny is that much of the Arctic is dependent on air transport. There's many places that have no road access. And as a result of that, the airport facilities are really important. We do have really good airport facilities in the big centers like Whitehorse, Iqaluit, Yellowknife, but a lot of the remote communities have limited airport facilities. They're mainly gravel runways. There's a few communities that have no airport or have very short runways that are accessible only to specialty aircraft like Twin Otters or Pilatus. And of course, the other thing is that they don't have precision approaches, so that in bad weather, there's limited access just because the navigational aids are not very sophisticated. Maintenance and weather information at the airports is not 24 hours a day in many of the communities, and so to get information, you often have to call someone at home or track them down so they can go to the airport and tell you what the weather's like right now or if the runway's been cleared, etc. So there's a lot of challenges just operating up there. And then the other thing is even getting access to fuel. I know when there have been many times that we've had a broken fuel truck in a community, and it might take 6 or 7 weeks to get the part up there. So in the meantime, there's fuel, but you can't get it to the aircraft. So planning has to surround where can we get fuel. So if we fly to X community, we may have to drop the nurse or the paramedic off there, fly to another community to get fuel, and go back and get them. The same thing happens in terms of having fuel available towards the end of the shipping year. Every year, the communities that don't have road access have to order the fuel that their community is going to need for the following year. And that fuel is shipped in by barge or sea lift to each of the communities. And it's a huge undertaking to plan for what a 12-month period is going to be for fuel requirements for the community. If they misjudge that, whether it's because they made a mistake or whether it's because there was extra activity in the community and extra airplanes in and out because of charters, for example, they may start running out of fuel. And not uncommonly in June and July in particular, because the barges will start coming hopefully in August, it is not uncommon to have rationing of fuel for aircraft and ultimately not fuel available for aircraft for a few weeks until that resupply arrives in the community. So those are challenges that you don't see in the south, and they're enormous challenges for the aviation component of the air ambulance. I think everyone's aware that it's pretty exciting variable weather up in the north, and the winters can extend from September to June. So, you know, you don't have a nice fall, you kind of have cold weather in August and then winter. And you also have very late springs in that there are times there's still snow in July. And of course, depending on how far north you are, that can be more extreme than in other regions. But it is important. I'm a Manitoban, and I thought I'd felt the cold, but once I stayed in Rankin Inlet for a few days in a blizzard, I realized what cold can do to you and that it can take your breath away. So it is a very challenging place to go out and transport patients and to keep them warm, to move them from the health center to an airplane that's been sitting out in the cold for an hour and is cold soaked. It's quite challenging to keep IVs running, to keep patients warm. And I've had an endotracheal tube actually snap right off on a patient many years ago because I just couldn't keep it warm enough, and in the cold it was brittle and snapped off. So those are the kinds of challenges that you do run into. The blizzards can last for days, and in the spring and the summer and the fall, you can get a lot of fog, particularly on the communities that are on the coast. And in Nunavut, that's pretty much everybody other than Baker Lake, and there's many communities along the northern part of the Northwest Territories too, that are right on the Arctic Ocean, and so they're really impacted by that weather situation. And the other thing that kind of impressed me a lot is how much darker it is up there, and for certain periods of time, there is no light in some communities. You're always working in the wintertime. It seems like all the medevacs happen at night, or, at certain times, any time of the day is night. So, having adequate lighting, we used to wear headlamps so that we could see what we were doing, but it is a very challenging thing to always work in the dark for months at a time. There are other challenges which I'm sure we'll hear about. One of them, of course, is communication systems. There aren't enough lines. It seems the more the population changes, the more lines are being used, and it's not uncommon to try to make a call and not be able to get a call made for a few minutes until somebody else hangs up. And a lot of the communication is based on satellites, and therefore the connections are not great. The other thing that happens is cell service is spotty to non-existent in some communities, and even in places like Yellowknife and Iqaluit and Whitehorse, certain suppliers or providers are not supported. So having a nice cell phone that works great in Winnipeg or Ottawa may not get you too far in the north. Internet access is slow in some cases. It's very molasses slow. And so, again, that's another means of communication that we take for granted in the south that's very difficult, especially in some of the more remote places up in the Arctic. So those are huge challenges, and the final one is cost. It costs a lot of money to live in the north. I have a picture there. I don't know if you can see it, but it's a $200 turkey. But so food costs are very high. The cost of doing business in general, whether it's heating your home, fueling your vehicle, if you want to travel out and have a holiday, there's not a lot of seat sales out of the north. And so it's just an expensive place to live, and therefore expensive to provide service in. Those are the general challenges, and now I think I'd like to turn it over to Dr. McDonald, who's going to give us the rundown on the challenges in Nunavut, because he's going to start the whole thing off, and then we'll head across the north.
So while we're waiting for Dr. McDonald to get set, we did have one question came in from Kate on our panel, and I'll just read it off for you, Penny. She's just saying, knowing what you know now from your experience, what piece of advice would you give to someone who is considering becoming part of an air medical transport team?
Well, one thing is get a good parka. I think really the big thing is that there's some opportunities up there, and generally the air ambulance providers are always looking for good qualified staff. I would say the first thing is make sure you have the experience to go up, because if you're keen but not experienced, it can be a very traumatizing place to work. But if you have the experience, it's an excellent learning ground. You will, I can guarantee you, learn a lot. But you do want to know who you're working for to make sure that they're honest, that they have a good safety record. I'd look at things like, has there been a lot of turnover recently, and if so, why is that? See if you can talk to the staff, not just the people that are running the show, because you might get different stories, although I used to try to be always very honest with the staff. Do they have good training that will prepare you, not just initially, but recurrently, so that there's a mechanism by which you can keep your skills up and not feel rushed in getting out there as a solo provider? Is there a good mentorship program? How do you get a good mentor to to be with you and provide you with the support you're going to need? Do they have a good support system so that if you get yourself into a situation, you have people to call who are knowledgeable and experienced in the region? I think these are the things that I would say to people, because the obvious thing is make sure you get good training, but the less obvious is the amount of support you're going to get as a provider up there.
All right, thank you. Great answer. And the one thing you didn't mention was with all that flying around in the north, you didn't mention that I'm sure the lineups at airport security at Rankin Inlet are much shorter than they are in Toronto. So that's one of the benefits.
Yeah, good point.
All right, we'll now hand over to Dr. Sandy McDonald to tell us the story about air medical transport in Nunavut. Over to you, Dr. McDonald.
All right, thank you, Doug, and thank you, Penny, for your great overview of medevacs in the north. So I'm going to focus on Nunavut, and there'll be a little bit of repetition here, but I'm going to skip over the repetitive parts and deal mainly with the issues that make Nunavut unique. So in order to understand what we're saying about medevacs, you will need to know a little bit about the healthcare system in Nunavut. I will give you a case, as Penny did, that will demonstrate the complexities of medevacs, brief case, and then we'll take a quick overview of the system in Nunavut and the challenges we face. So again, the maps are absolutely necessary to understand the north. You can see Nunavut is the largest of the territories and the most sparsely populated. It extends over about 7 provinces, and so as Penny mentioned, it does complicate our referral system a bit. We're not able to run a centralized system like they are in Yukon and NWT because of our 3 regions that are so far apart. I don't need to dwell on this since it's already been covered. Nunavut's a big place. It's 2 million square kilometers and has a total population of about 32,000 people. This slide has a few limitations. The take-home message from it is look at all of the movement north-south across Canada. The slide refers only to Inuit people. It was developed by Inuit Tapiriit Kanatami, which is the Inuit, the organization representing Inuit in Canada. So it gives short shrift to the Yukon, where no Inuit live, but it'll give you a sense that all the travel is really north-south in the north. There's very little travel east-west. It's hard to travel east-west. It's even hard for me in Iqaluit, where I live, as you can see in the far east of Nunavut, to get to Rankin Inlet and Cambridge Bay, the other centers in our territory. This is a map of Nunavut all by itself. As I said earlier, 2 million square kilometers, huge area, 32,000 population, and these 32,000 people live in 26 small communities. The largest of these communities is Iqaluit, down in the right-hand corner there, the far east of Nunavut, and it's the capital with about 8,000 people. It is the other regional centers are Rankin Inlet, which you can see on the west coast of Hudson Bay in the purple area, and then Cambridge Bay in the center. It's the old Central Arctic, which is the other regional administrative center. For administrative purposes, Nunavut is divided into 3 regions. The green region is the Qikiqtalik region, which goes right up to the high Arctic. The purple region, which is on the west coast of Hudson Bay, is the Kivalliq region, which Penny mentioned earlier, and the blue region is the Kitikmeot region, and the administrative center for that is Cambridge Bay. All of these communities have health centers. There's one hospital in Iqaluit. There's a regional health center in Rankin Inlet that has a few inpatient beds and takes low acuity patients. All the rest have small health centers, which are staffed with anywhere from 1 to 7 community health nurses. Most of them, vast majority, do not have physicians all the time. They'll have family docs who come for visits once a month or so, depending on the size of the community. But the community health nurses really do everything there, from running well baby clinics, well woman, well man clinics, to dealing with the most dire emergency, as Penny described earlier. So referrals, as Penny mentioned earlier, if we go from west to east, from the Kitikmeot region, the blue region, the referral center there is Yellowknife, and for tertiary care it goes on to Edmonton. For the Kivalliq, it is to some extent Rankin Inlet, and then down to Winnipeg. And for the Qikiqtaaluk region, it's Iqaluit, and then on to Ottawa. Now, I'm going to tell you a brief case history here, which will illustrate some of the logistical challenges as well as medical challenges we face in Nunavut. And I'm going to stick with this map because you need to understand the geography involved in this case. Well, this case is about 10 years ago, not as long ago as Penny's, but a while ago. And it involved the community of Grise Fiord, which you can see at the very top of the map on Ellesmere Island, which is the most northerly civilian community in North America. It's a tiny place of 150 people, and it has a one-nurse station, the only one-nurse station in Nunavut. The patient is a 2-month-old ex-prem with a corrected age of, I believe, about 10 days, who went home to visit relatives in Grise Fiord and developed respiratory distress. So this baby, it always happens in the middle of the night, was brought to the health center at 12:30 in the morning with apneic spells and respiratory distress. I'm not going to go into the details in the interest of time, but the baby was very sick. The nurse there was a quite experienced nurse who realized immediately that the baby was too sick to stay in Grise Fiord. So then that begins the challenge of getting the baby safely to the appropriate level of care. So we launched a medevac from Iqaluit in a King Air, which at that time, with the medevac provider, they flew the King Airs to Resolute, which you can see up on the high Arctic there, and that's about a 1,000-kilometer trip. So the King Air 200 would take 3 to 5 hours, depending on whether it had to make a fuel stop in Pond Inlet or Nanisivik. Then the medical crew, which at that time consisted of a paramedic and a PEDS resident, would change planes and get in a Twin Otter to fly to Grise Fiord, because Grise Fiord has a very short airstrip that's gravel and has a very tight approach and a very limited, strict limits on the wind velocity across the airstrip. So they flew to Resolute. They launched about 1:30 in the morning. They got to Resolute around 9. They got to Grise around 10:30. And then they got kind of bogged down there trying to start an IV on the baby, and they did a great job, but those of you familiar with transportation issues and medevac issues know how we can all get a bit distracted when we're in these situations. And they spent several hours trying to get an IV started on this baby. Finally, around 3 o'clock, they got the IV started. And then the doc in Iqaluit spoke to them on the phone, and they were saying, well, now we need to intubate the baby. The baby was in severe respiratory distress. However, the nurse came on the phone to the doc and said, if you don't get these guys out of this health center, I'm going to kill them. The nurse had now been up for 15 hours, was exhausted. And at the same time, the manager of the medevac company called the doc and call and said, if they don't get out of that health center in Grise Fiord within the next hour, my pilots are going to duty out in Resolute, and they're going to be stuck for another 12 hours in the high Arctic. So at that point, the doc made a decision, a medical decision. He knew the system well, and they decided that they, instead of flying from Grise Fiord to Resolute, they would fly to Pond Inlet, which is a large health center with 6 nurses, and they got another plane from Iqaluit that wasn't a dedicated plane, it was a charter plane that was available, and sent a GP anesthetist up with another medic, met the team in Pond Inlet, intubated the baby, and flew to Iqaluit. By the time they got to Iqaluit, it had now been 24 hours since the medevac was initiated. The baby was stabilized further at Iqaluit and was sent down to Ottawa, arriving there around 9 o'clock in the morning. The baby was admitted to PICU. In fact, the baby did fine, but the whole thing took about 36 hours, involved multiple planes, and many medical personnel. So I'm just going to show you, this is Grise Fiord. We already saw it once. We're looking east. You can see the little village down in the center of the picture, and just to the left, if you look to the left, you'll see a gravel strip running off to the left-hand, lower left-hand side of the picture. That's a beautiful day in July in the high Arctic. That's the health center in Grise Fjord. That's the map again. And here's some of the aircraft, the workhorses of medevacs in the north. It's a Twin Otter, which we've already seen. There's a King Air, which is one of the real workhorses. That's a 350, but we use one 350, but many King Air 200s. And that's a Lear 35, which was the plane that eventually brought this baby to Ottawa. So that summarizes the logistics. So the planes traveled over 3,500 miles to get this baby, who was about 900 miles from Iqaluit to start with. It involved 8 pilots, 4 separate aircraft, 2 King Airs, a Twin Otter, and a Learjet, and 8 medical personnel, not counting the nurses and doctors in Pond Inlet, Iqaluit, and Chio. So as you can see, this was an interesting medical case, a baby in respiratory failure, but it was an overwhelmingly complicated case from a logistical point of view. And as I say, this case, I actually talk about it for an hour at conferences because it's such a fascinating case. But as I say, in order to practice good medicine in the North, whether you're a nurse or a doctor, you need to understand logistics. So to a great extent, we're all logisticians. Now I have a question here, and Doug said that you like little quizzes. I don't think we have time for, how would it work, Doug? Would you have to then, I would ask the question and people would submit answers? I don't want to spend too much time on it. I can just run through it, I think, in the interest of time.
Sure, yeah, why don't you go ahead?
Okay, number of dedicated medevac missions in Nunavut per year. So we have a population of 32,000. It's a small city in Ontario or BC. So we have options I've given you are 500, 1,100, 1,700, 2,200. And the answer is 1,700. So for 32,000 people, we do 1,700 dedicated medevac missions per year, and that doesn't count the scheduled flight when we send people out for scheduled medical appointments. So it's a busy place for medevacs. That's about 5% of the patient visits to the health centers result in medevacs per year. As the breakdown per region, most of them are in Iqaluit, which is where half the population of Nunavut lives, and then in Kivalliq, which is the next most populous region, and Kitikmeot is the smallest region, has about 1 a day. What are they? Most of them are respiratory. Mental health account for the next highest percentage, trauma 12% approximately, and then GI, OB, and neurological issues comprise the smallest grouping. And another question, Doug, so we won't wait for the people to send in their answers, but the proportion, since this is about pediatrics mainly, the proportion of dedicated medevacs per year for pediatrics and infants, 10%, 20%, 30%, 40%. And the answer, ta-da, is 30%. So in Nunavut, we do over approximately 500 transports of kids and infants per year, which I've always used this number, the 30%, but when I actually calculate it out, I realize that we're doing 500 trips a year, we ought to be good at it. And I do think we're quite good at it, but there are many limitations and challenges, some of which Penny's already identified. So we're in fairly big business. I don't know about your centers, how many transports you have coming into your centers, but 500 a year is fairly significant. So a bit of an overview. It's an expensive business for the government of Nunavut, who pays for most of it. The federal government pays for some part of it because most of the people who live in Nunavut are Inuit, and they do have some rights under the non-insured health benefits program. But the total cost for medevacs alone is over $30 million a year out of a budget of about $300 million for the Department of Health in Nunavut. So it's a significant amount, 10% of our budget. The individual cost, as you who are in the transport business are well aware, depends on, well, on the aircraft you're using, but it depends mainly on how far you're flying, and these can range anywhere from a couple of $1,000. The shortest trip in Nunavut would be about 100 miles by air, to 30,000 plus, depending on if you're going to Ottawa or down to Winnipeg and so on. For a population of 32,000 in 26 small communities, we have 6 dedicated King Airs and 1 dedicated Learjet based across the territory. There's 2 King Air 200s in Iqaluit and the Lear, There's 2 King Air 200s based in Rankin Inlet, and a King Air 350 and 2 in Cambridge Bay, and a King Air 200 in Yellowknife, which backs up the King Air 350. So what are the big challenges? Well, one of them is we have 3 systems. As I mentioned earlier, it's a large territory, but it's a very decentralized territory. We don't have the advantage of one great big place that everything feeds into, as they do in Yukon and to a great extent NWT. Geography, I won't belabor. Penny's gone over that well, and the weather. The lack of specialist clinicians, which is true. Most of the care is provided by generalist nurses and generalist family physicians. We do have pediatricians in Iqaluit. They're generalist pediatricians. But we have teams that are quite well trained for adult and pediatrics, and then we do the best we can for the neonates, and that's another issue that has been debated a great deal, and I won't belabor it now, but if anyone has a question, I'd be happy to talk about it. One of the big challenges that Penny didn't mention, and may come up later on, is demand fluctuations, and I'm sure you all face that in your systems. As we know, it's either the situation seems like nothing's going on, or everyone wants a medevac at the same time. And that's a real challenge for us, and resulting in situations where we have to triage our medevac resources in all regions. We have to prioritize based on the severity of the illness and how long people have been waiting. And that does provide significant challenges and a great deal of frustration for the nurses in the small health centers who are stuck with a sick patient for a long time. That's the end of my presentation, and I'll just finish off with a picture of my daughter, my little blue-eyed Inuk kid. Thanks very much.
All right, thank you, Dr. McDonald. We did have a question that came in about the percentage of transports that were pediatric, and you did have that poll slide that showed that was 30% of your cases. They were also asking, Penny, if you could give us if that's comparable to your experience in the number of remote transports that are coming down to Winnipeg. In your experience, is it about that 30%, or is it more or less than that?
Yes, those stats that Dr. McDonald quoted are probably the same stats as what would have been provided when I was with Keewatin Air, and that was our experience. Is there's a lot of kids, and most of them are probably under 18 months. So it's respiratory distress, it's that sort of thing. And I believe in the last year we had 70 under 6 weeks. So 70 neonatal transports under 6 weeks.
And Doug,
that year.
Doug?
Yeah. Yep.
Yeah. Just to elaborate, the breakdown for pediatric and neonatal or infant transports is not those stats I showed about 30% being respiratory. They'd be probably 80% respiratory. Mm-hmm. So almost all of the pediatric and infant transports for people for respiratory distress, bronchiolitis, pneumonia, and prematurity among the infants.
Oh, okay. Oh, interesting. Okay. Sarah's also asking, is that including northern Manitoba as well as Nunavut, Penny?
No, actually the stats that he's used and that I'm familiar with are almost all just Nunavut patients. But when we were working in northern Manitoba, it would be a smaller percentage, more like 25% would have been pediatrics. And the neonatal team in Manitoba would be handling the sick babies that were under 6 weeks, or up to 6 weeks. Corrected age was their criteria.
All right. All right, thank you very much. All right, we're now going to move a little bit further west to the western part to hear Cara Levy talk about her experiences in the western part of Nunavut and the Northwest Territories. So over to you, Cara.
Thank you very much, and thank you, Dr. McDonald and Penny, for such a wonderful introduction. And I feel the wave moving from the east to the west. And in fact, when I was preparing for this presentation, it was very telling in terms of epidemiology, of the patient presentations, the illnesses, and how it really does change. And hopefully my presentation will be able to demonstrate that a little bit. Just a little bit of background, because I know we've got lots to share still, and I don't want to impose on anybody's time. But my background, I really sort of, I was a nurse for about 5 years prior to, being initiated into the air ambulance medevac world. I started in 1994 in Iqaluit, and at that time there were no dedicated air ambulance services, medevac services. We worked as nurses in the hospital, and when an air ambulance transport was requested, those of us on the transport team would run down to a large room, try to pick out the supplies we thought we might need, get ourselves to the airport, and fly to the community to transport these patients. And I remember really early on in 1994 being absolutely mesmerized by the communities, by the Inuit, by the community feeling that you felt in the north, because you really have to pull together to be able to survive, quite literally. And I'd flown into Pond Inlet, which is a beautiful community. At 5 o'clock in the morning, it was July, the sun was shining all the time, almost 24 hours of the day, landed on the wonderful strip there and came into the community. And I had originally been called to transport one 13-year-old with a decreasing LOC, and when I got there, I was presented with two young girls who had been experimenting after some trauma in the community with some drugs and alcohol, and both were unconscious and both were intubated. And so I found myself trying to transport two 13-year-old intubated patients without a ventilator, with minimal oxygen, transporting them from the health center in the back of a pickup truck to our small aircraft, and then flying a very long flight with limited supplies from Pond Inlet back to Iqaluit. And I was in love with the north. I was in love with transport, and that was, I guess, the start of my career, in which I thought there's got to be a better way to do this. I really want to continue with this. However, I think there's got to be a better way. And my career really has been focused around what is that better way. I've spent many years educating. I am now a nurse practitioner. I've spent many years in all across North America, the United States and Canada, working with multiple different air ambulance programs, rotor wing, fixed wing, international flights, those kinds of things, and really created a repertoire that I could pull from to be able to develop air ambulance programs and really keep us moving and keep us addressing the challenges and moving forward. And so when Advanced Medical Solutions, otherwise known as Medic North, was awarded the first air ambulance contract in the Northwest Territories for us in 2007, we really had that opportunity to sort of implement all of the things that we were able to learn around through the years, and look at how we could, in a very remote environment, try to implement some of the things that I'd seen and experienced in many different parts of the world. So I'm going to present a little bit of that. Of course, I could talk about this forever, but I will narrow my focus for the purpose of these next 15 minutes. Advanced Medical Solutions is really a critical care transport team. We transport in the Northwest Territories and Western Nunavut in the Kitikmeot region, as Dr. McDonald has said. We call ourselves a generalist team. But however, I would challenge that in that our specialty really is transporting all age groups of all acuity levels from remote communities to tertiary care centers, despite our challenges, despite our rugged geographical and weather conditions, despite IV lines freezing, and as Penny said, endotracheal tubes freezing and breaking, despite the mechanical issues, equipment on a good day in a hospital setting in an ICU breaks down. Imagine that after flight in these remote and really rugged environments. So that really is our specialty. And when you look at our service area within the Northwest Territories and Western Nunavut, the right-hand side line obviously is not quite correct. It's not straight. It goes out quite a bit more. But just to get a sense of our geography and our land mass, if you follow the lines down, when you look at the provinces, our service area really takes up Saskatchewan, Alberta, and for the most part, the majority of British Columbia. And we do that with very limited resources, and I'll get into that in just a second. So just to get an overview of the landmass we're really speaking of, and the geography is just amazing. As Penny said, the distribution of population is very in the Northwest Territories, 44,000 residents in 33 communities. And Yellowknife is the largest community, and it has 20,000 people. So now you have 24,000 people spread over 32 communities. That's very sparse. And in Western Nunavut, in the Kitikmeot region, there are 7 hamlets, and the total population was 5,300. So again, very, very sparse. In terms of healthcare resources, in the Northwest Territories, there are 4 hospitals. Stanton Territorial Hospital is located in Yellowknife. It is the largest territorial hospital and the referral center within the territory and Western Nunavut. There's an Inuvik Regional Hospital up here, and we'll talk about that service area in just a minute. There's a small Hay River Hospital as well, and there's a small Fort Smith Hospital, sorry. And these are really small hospitals that don't really provide a lot of acute services. Patients will be transferred out for acute care and then brought back to those communities for continued care along the trajectory of their illness. We have 2 health centers with physicians that are there the majority of the time. One is Fort Simpson in the Northwest Territories, and the other is Cambridge Bay. And then the remaining communities that are left either have, there are a couple that still don't have any nurses in the community. They have a lay practitioner that calls over to another community to get assistance when they require it. And then nursing stations that go anywhere from 1 to 4 nurses that reside and work there. The referral patterns in the Inuvik region in the Beaufort Delta, we transport patients from the communities such as Tuktoyaktuk, Aklavik, and Paulatuk back to the Inuvik Regional Hospital. And on the right-hand side there you can see an aerial view of the hospital and really Inuvik. That's about what it looks like. That's a beautiful summer day in Inuvik. And then the rest of the referral patterns all come down to Yellowknife. So patients that are too sick to stay in Inuvik. Inuvik does not have a CT scan. It doesn't have, it has an operating room, but they do just very general surgeries. There's no specialty services there at all. So any patients that need further care come down to Yellowknife. And obviously all the patients within Western Nunavut, so the Kitikmeot region, come to Yellowknife. And that's the Yellowknife Territorial Hospital there on the right-hand side on the edge of Frame Lake. And then the referral pattern, obviously, from Yellowknife goes down to the Alberta Health Services. For the majority of patients, they end up in Edmonton. So for the pediatric patients in the Stollery Hospital, we do transport other patients to all of the different hospitals in Edmonton. When Edmonton is over capacity, we will fly to Calgary. We may fly to Saskatoon. We have flown occasionally to British Columbia, but for the majority of the tertiary care center, we go to Edmonton. Approximate flight times, and this is, when the stars align. Cambridge Bay to Edmonton is about 5.5 hours. Depending on the aircraft, the majority of the time we do have to stop for fuel, but there are some aircraft that we can make it all the way. Inuvik to Edmonton is again 5.5 hours, and again with a fuel stop. That's not including the fuel stop. And our Yellowknife to Edmonton, which is the bulk of what we do when we're flying, most patients will come into Yellowknife and either stabilize at the Stanton Hospital, or we refuel, ramp transfer, and get them into a different aircraft so that the aircraft from the remote regions can get back to those remote regions. Is 2.5 hours to fly. Air ambulance resources. So how many planes do we have? We have a total of 6 planes to take care of this entire area that we speak about. We have one dedicated King Air 350, so 350 in Cambridge Bay, and that is the white aircraft that you see in Western Nunavut. We have another dedicated King Air 200, that's in Yellowknife. And the reason that we have them separated, and it's dedicated specifically to Nunavut, is because the weather patterns, as you can see, Cambridge Bay is just on the ocean, and the fog within Cambridge Bay really prevents us from flying, and the ice fog in when we do change seasons, when we have our very quick summertime, so in spring and fall, if you will, in the north, the ice fog that comes in from the ocean is really impressive, and grounds our aircraft in Cambridge Bay. So having a secondary aircraft in Yellowknife really allows us the opportunity to go out and service the other communities within Nunavut when our Cambridge Bay aircraft can't, and as well as for those times when there's multiple requests for transports, both aircraft can fly at the same time. We have 4 dedicated aircraft for the Northwest Territories. 3 reside in Yellowknife. They are King Air 250s, and then there's one in the Inuvik, in the Beaufort Delta sitting in Inuvik, and that services obviously the Beaufort Delta area, flies down to Yellowknife, transfers patients that need to continue on to Edmonton, and then flies back up to Inuvik. In terms of medical resources, we fly critical care teams of a nurse paramedic. We have 1 critical care team for each aircraft, basically. So 1 in Cambridge Bay, 1 in Yellowknife for the Kitikmeot region. And then we have a critical care team for each of our aircraft in Yellowknife, and another critical care team plus 1 extra in Inuvik. And so we have a total of 3, 4, 5, 6, so 6 teams that fly with all 6 aircraft. We also, as Penny discussed, and as Dr. McDonald provided with a great example, fly in non-dedicated aircraft. So we have flights where we'll go in rotor wing, so helicopters. We have flights where we need to land on tundra tires because our regular aircraft tires aren't good enough, and that's the picture down on the left-hand side on the bottom, and we fly in Twin Otters for those types of flights. We do floats. It's very challenging to transport patients in and out of a floating aircraft, but we manage that, and we do have access to a Learjet when we have long transport times and when stopping and changing altitude is really detrimental to that patient. So, and of course, not only does the Twin Otter land on tundra tires, but it lands on skis as well, and Dr. McDonald showed a great picture of that. So our staff not only have to be these flexible, competent, energetic staff, they have to learn lots about different types of aircrafts, lots about, again, the logistics of how does each piece of your equipment fit into each one of these different aircrafts, how do we use them, how do we be safe around them, those kinds of things. A little bit about statistics. In terms of statistics for our region, the Cambridge Bay region, so Kitikmeot, we do approximately 300 flights a year, or transports a year. We transport about the same number of patients in the Inuvik region. 70% of those go back to the Inuvik hospital, 30% come down to Yellowknife, and then out of the Yellowknife area, we transport approximately 1,000 patients a year. So with those 3 aircraft, they're flying quite a bit. So we're quite a busy service. This slide, hopefully you can see it well. I'm going to move from the east to the west now in terms of statistics. In the Kitikmeot region, because of the discussion today with CAFC, I wanted to focus on sort of our patient population. The lighter lines are adults, the a little bit darker blue are pediatrics, and the darkest blue is neonates. So you can get a sense of, this is data from 3 years, from April to April 2012-15, about our call volume per month. And so for adults, we fly approximately 15 to 30 adults a month. We fly less pediatric patients, approximately 5 to 15, and then neonates, we might do a handful, if you will, each month. So you can get a sense of what the population is that we're transporting. When you look at our total population in a little bit easier to look at, 66% of the patients we transport from the Kitikmeot region are adults, 28% are pediatric, and 6% are neonate. Northwest Territories, that's very different. And when you think about epidemiology, bronchiolitis, RSV, some of the social factors that affect health care, you see it change as we sweep to the west. We have a extensive adult population. Our pediatric population drops significantly, and our neonatal population stays about the same. So in the Northwest Territories, we transfer about 90% of our patients are adult, whereas in the Kitikmeot region it was 66. only 8% of the patients we transport are pediatric, whereas in Kitikmeot region is 28%, and the neonates are about 2% versus percent in the Kitikmeot region. I have a slide on obstetrical transports, and it just looks at the differences between Northwest Territories and Nunavut. Obviously, the Northwest Territories are numbered higher, but you can see, and it actually was, as Dr. McDonald was speaking about in terms of feast and famine and what happens in different months, how the call volume can be significantly different month to month, and that really expands your and puts pressure on your resources. And then, so when you look at our total emissions, 5.5% are obstetrical when you compare them across the board. I've also involved, I'm going to talk a little bit about psychiatric transports. We don't think about that as being such high risk more in the south, but for those of us who have no transport patients and we need to transport acute psychiatric patients by air, it's really quite a safety factor for us, and we looked at as high risk. And so when you look at the types of patients that we fly, 6.8 of the adults and 1.6% of pediatric against all other emissions were psychiatric patients. When you combine the stats from Northwest Territories and Nunavut, 80% of the patients that are psychiatric are adults and 20% are pediatric. So we have I think, a good population of pediatric patients that have psychiatric needs that are transported by air. And then critical care transports. So when you look at the overall statistics, 31% of them in Nunavut are adults, 54% in Northwest Territories are adults, 12% are from the pediatric population in Nunavut, and 3% are pediatric in the Northwest Territories. For this slide, there was no differentiation between peds and neonates, so it's from the age of 16 and below. So if you just kind of look at specialty transports, we say we're a generalist team. Our pediatric population is 8 to 28, depending on which region we're in. Neonate is 6%, obstetric 6%, psychiatric is 9%, and critical care is 12%. And so, one would think, well, if you're a generalist team, you're mostly taking care of us, and maybe a small percentage of what you do is specialty. But depending on the region, adults, plain old adults, whether they're medical or trauma, are only 39 to 63%. So we do a lot of specialty transports, and despite the fact that we're a generalist team. So we need to have skills and knowledge and ability and competency in all of these specialties, as well as take really good care of the adult population that we see. It's quite challenging in terms of how we prepare our staff and how we maintain their abilities and competencies. We do have a specialty team that will come to the Northwest Territory from AHS. We have an NICU and a PICU team. However, they don't transfer it very often. They're able to come when there's no other transports occurring in Alberta. Obviously, Alberta will be their primary focus. And when they do come up, they only come to Yellowknife or Nunavut. The PICU team actually rarely comes to the Northwest Territories. SCU team will come a little bit more often, and they transport approximately 20 patients a year out of the Northwest Territories. I don't have those directly. They were given to me by the GNWT. So if there is anybody on the line from the Stollery or is able to provide a little bit more statistics, that'd be good to talk about. They don't often, and what you need to realize is that very few times does the patient originate from a Nunavut or from Yellowknife. They will originate from one of those other 33 communities where our team goes out, stabilizes, intubates, fluid resuscitates, brings them into the tertiary care centers, and then the team comes and meets us there. So despite the fact that we do have some access to fantastic specialty teams, it takes them 5 hours to get to us, and so we need to do an initial treatment. So I just wanted, we've heard a couple of cases, and we'll hear another one in just a minute. I just wanted to talk a little bit about the logistics of what this looks like. So you get a call for a 32-week premature labor with ruptured membranes in Joehaven, which is in the Kitikmeot region, one of the furthest communities. The woman is 4 centimeters dilated with regular contractions, so you know that you're into this. The timelines for transport, I think, are impressive. We think about the golden hour, and we know that the quicker that pediatric specialty care gets to the patient, the better their outcomes. And so I just wanted to take a second to talk about the things that need to occur to transport a patient from the north to the south. So there's the assessment and decision making to actually transport the patient, and that's often occurs between the community health nurse and the community physician by phone. That can take 30 minutes to an hour. Oftentimes there's a discussion with the obstetrician in Yellowknife. Do we bring them to Yellowknife or do we transfer them to AHS? That takes about 30 minutes. Then we call to Rapid North and we do a consultation. That takes about another 30 minutes. We establish a plan of care. Most responsible practitioner within the Northwest Territories and Nunavut, we maintain the most responsible practitioner is not a transport physician. It can be the physician who's sending, or it can be the acceptant, or most likely a combination of the two. And then the actual the air ambulance is dispatched. It takes us an hour to get moving, and then from Cambridge Bay to Joehaven, it can take 2 hours for our air ambulance crew to get there. We have to transport in and start our assessment and stabilization. So right there, by the time our team gets there, we're already looking at 6 hours in, and that's a good day. And then the flight to Yellowknife is about 3 hours. Transport to Stanton's about 30 minutes. Then they're assessed by an obstetrician. Further diagnostics can be for 1 to 3 hours. Another consult with Rapid North to say, yes, we need to transport this patient on to Alberta Health Services. Dispatch the second air ambulance crew can take an hour. Again, we get in there, stabilize, prepare for transport, and then another 3.5 hours, 2.5 of that flying, and then there's a significant transport time from the Edmonton International Hospital or International Airport into the hospital. And so total transport is 16 hours from start to finish, and that's not with likelihood of the case that I've provided is somewhere in there the mother's going to deliver, and now you have a mother to take care of as well as a neonate to take care of in a very small, cramped plane in the middle of nowhere and with very little resources. So I think that that's important when we're talking about timelines and how quickly we can transport people. Challenges that we've had in the north, we've talked a lot about the challenges. I think we've done a really good job of identifying some of our challenges and how we can work through those. In the past, there was no coordinated resources. So basically it was first call, first serve. We've got this many planes, this many calls comes in. If you happen to be the fourth person to call and the 3 planes are gone, you have to sit and wait. As of the last 6 months, the Northwest Territories has developed a dispatch center called Med Response, and they're fundamental in really triaging the flights that come in, the requests that come in, how we utilize our limited resources, how we provide support for the nurses in the community. They get directly linked in with the physicians anytime they need to. They get callbacks from Med Response to find out how the patient's doing, and we're able to link in with multiple practitioners. So the flight team can link in with the Rapid North team, physicians, as well as the sending physicians, so we can create a plan of care for patients who's identified as critical from the very beginning. So that's a fantastic dispatch center that's just started and in its infancy, but really has quite the potential to take us far. Balancing the psychiatric care and safety. And so, as I said before, we in the past, we've transported all our psychiatric patients by air. We don't have a choice. How do we know whether or not these patients are going to escalate in flight and the risks that occur? We did extensive research and have developed a pre-flight psychiatric risk assessment tool for those types of patients that will potentially get worse in flight, and we bring our CMP along with us on those flights. Before it was sort of a best guess in terms of the patient's history and if they've escalated before. Now we're actually using a quantitative research evaluated tool to determine which patients are most likely to escalate in flight. So that's been a application of research to our environment to allow us to really try to utilize our resources to the best of our ability and not pull RCMP when we don't need them. Obviously, we have high-risk patients and skills with low yield patient populations. So how do we take care of those really sick neonates, those really sick pediatric patients? When that's not the majority of what we do, and when we're not situated in an NICU or a PICU where we are exposed to those types of patients all the time. Just recently, in the last couple of months, we've developed a simulation center in Yellowknife where we can have high-fidelity simulation with all patient populations. So we have a neonate, we have a pediatric, we have an obstetrical, high-risk sim, we've got adults, we've got airway, we've got lots of things, and we're just in our infancy in getting that simulation center up and going, but we hope that that will allow us to practice more skills and gain some better skill retention for some of the things that we looked at. And we have, newer equipment. And so while this doesn't look exactly like what the NICU and the PICU teams use, we have newer equipment, syringe pumps. We've got ventilators that work specifically with neonates as well as pediatrics, so we don't have to have multiple ventilators for different patient populations. We've got our NeoPuff, that kind of thing. But if you notice, it is mounted on a number 9 stretcher. It's not mounted on a fancy stretcher because, as Penny alluded to, only 4 of our communities have ambulances. So the other 29 communities in the Northwest Territories, and none of the communities except for Cambridge and Nunavut actually have ambulances. So we are trying to transport this isolate, this very expensive equipment in the back of a van, and as you can see, it's very cramped, it's very crowded, and it's very, very challenging to be able to move our critical patients safely in these types of vehicles. But we still have challenges. We still have things we're still searching for solutions for, and our continued challenges include accreditation and competency standards. So to CAFC, to the Canadian Association, obviously, of Pediatric Health Centers, for CAMES accreditation, for Accreditation Canada. When teams like this and groups like this look at competencies for people who transport neonates and pediatrics, they often think of teams that originate from an NICU or PICU, or at least have access to an NICU or PICU for ongoing education, training, skill development, those kinds of things. Our teams in the North don't have that. And when we have attempted to work with other centers, obviously the number of learners that are trying to go through the stollery is phenomenal at best. And to try to get teams from, not the province of Alberta to come in and work is quite challenging. So I'm interested to hear if anybody has some suggestions on how we take those recommendations in terms of competencies and standards and how we can actually implement them. We have our simulation center now, so hopefully working with other centers and doing it through, the internet in a sim setting will help us a little bit. So those are the things we're looking for. And if you have any questions, please feel free to contact me at any time. Thank you very much.
All right, thank you, Kara. Fantastic presentation, and we did have a few questions come in, but I think we're going to save those to the end just so we can squeeze Sheila's presentation in. We are recording this session, so if people do have to leave, they can always come back to the end of the recording to catch the questions. So we will come back to the questions as long as our presenters are able to stay a little bit over time. But in the interest of time, we're going to go as far west as we can get in the north, and hear from Sheila Thompson to talk about the Yukon and the western north. To hear Sheila talk about her experiences in the Yukon. Over to you, Sheila.
Great, thanks so much. I really appreciate being invited to participate. And just quickly, a little bit about me. I have a background as a neonatal pediatric critical care nurse. I've been a flight nurse in rural and remote northern Manitoba and Nunavut. And I've been a consumer in northern Manitoba, Nunavut, and in Yukon of medevac services. So for about 30 years, I've been involved in a variety of those roles. And truly, I think the key to this presentation is that all northern regions are different, but we have similar challenges that we all face. My very first start with flight nursing was
when I was working for the government, and they basically had, before licensed air ambulances, they would put a nurse on call with a beeper, and you would get a call to go to a community. You would hop on a plane, non-pressurized mostly, no equipment, and no report, anything. I sort of related it to grabbing a six-pack and going to the game, and no preparation. And I did that once and had a very bad experience, and swore I would never do it again until I actually had some training, and then went through formal training in aeromedical. So I just wanted to talk a little bit about how the Yukon's a little bit different. The pictures, by the way, that I'm showing throughout my presentation are all taken by nurses who work and live in the Yukon. And this is a picture of the annual caribou migration near Old Grove. Sorry. There we go. I think we've all talked a little bit about some of these challenges, so I'm not going to go into a lot of detail, and I'm going to skip over the things that have been repetitive, just because we have all, as I said, similar challenges. A little bit about Yukon and why it's so different from the other territories. Our population total population is about 37,000. 77% of those live in Whitehorse. 20.9% are First Nations, and we only have about 386 births per year in Yukon. 16.7% of our Yukon population is less than 15 years of age. And I know when I worked in Nunavut, the majority of the population was under 20 years of age. So our population is much older. The average age of Yukoners is 38. Just to put it a bit in perspective in terms of our growth rate, in the gold rush in 1901, the population of Yukon was 27,000. So we've grown some, but not that much. And we represent about 0.1% of the Canadian population. One of the other things that makes us a little bit unique is that we have a large land mass, similar to the other territories. We have about 482,000 square kilometers, and to put that in perspective, the entire UK is 243,000 square kilometers and has a population of 63.5 million, whereas we have just over 37,000. We represent 4.8% of the land mass. And we are different in that we are connected by roads to all but one community. And so we have 4,800 kilometers of all-weather roads. And we're the main access to Alaska. So we have a lot of road traffic. And that leads to a lot of trauma in BC. Our healthcare services are similar to the other regions. The blue dots represent the 11 primary healthcare centers, which are staffed by nurses who work in an expanded scope of practice. And they run clinics Monday to Friday for primary care, and they also provide emergency services 24/7. There's no resident physicians in those communities, so physicians come and visit and do clinics. The two red stars are the two small cottage hospitals that are located, one in Dawson and one in Watson, and they're about 6 beds each. And the green star is Whitehorse, which is our main hospital and referral center. So you can see the community populations range from quite small outside of Whitehorse to the largest being about 2,000 people. We do have 82 resident physicians who are registered with the association and 180 non-resident locum specialists. And a lot of the attraction to the Yukon is lifestyle, so we have a lot of physicians who work part-time, so that's why I think we have so many registered. This photo just shows some of the challenges that affect our medevacs in terms of the topography. We have mountains everywhere, and so that affects how we can do medevacs, whether we can do medevacs at night, and how we can access different health centers. In summer, our population increases exponentially. One of the founding economics of Yukon is tourism. So this is a picture of a little town called Carcross, just outside of Whitehorse, about 45 minutes from Whitehorse. And they have a population of about 400 people that expands to over 100,000 visitors from all over the world that come through there in the summer. And so that definitely affects our health services. Cruise ships come into Skagway, Alaska, which is just over the mountain from Carcross, and most of those visitors come through Carcross to access the rest of the Yukon. One of the foundations of Yukon is adventure tourism, And the stats from last year were that 408,000 travelers entered the Yukon through the Canadian Customs, and only 40,000 of those were Yukoners. We have a huge population growth in the summer. Remote travel is very popular. Cell phone service is not available along the highways between communities, so there's definitely communication gaps. The EMS and nursing have a shared radio phone system, so we can communicate with each other and with Whitehorse EMS, and we use satellite phones as a backup. Weather and remote travel are challenges, as everybody else has spoken to as well. And so although we don't get the extremes of weather that they do in Nunavut, and I worked in Nunavut for 10 years, so I fondly remember those times. In southern Yukon, we don't get the extreme cold. In the northern, we probably are in the minus 30s to maybe a few days of minus 40 in the winter. This map just shows our EMS coverage throughout the territory. So the green stars are the volunteer services. So these are first responders who have about 2 weeks of training. There may be some slightly more advanced paramedics in some of those communities. And so the majority of Yukon is covered by a volunteer EMS service that works with the nurses in the health centers. The two communities that have small hospitals, Dawson and Watson, they have volunteer as well as some full-time EMS. And then Whitehorse is the main center. There's full-time EMS as well as that's where the air ambulance is based out of. The little blue circle around the red star, which is Whitehorse, signifies where 911 service extends to. The 911 service is only about 50 kilometers radius around Whitehorse. So as I mentioned, the nurses work closely with our trained EMS in the communities, and so we train regularly together, doing mock scenarios, mock traumas. For community nursing, we are purchasing a PED simulator in the next year so that we can do more simulations with pediatrics, and we don't have to borrow children of nurses who are working in the communities to work on our scenarios. And this just depicts one of the highway signs that you'll see in that 50-kilometer radius saying you're now leaving the 911 service area. So that does mean communication gaps. There is a project working on extending 911 service, sort of a modified service, that should be in place within the next, hopefully, 2 years. So in rural Yukon, nurses dispatch EMS in the communities, and they often also attend the scenes and accompany the medevacs to Whitehorse. You can see a helicopter hovering over the highway there, and there is a helicopter service, which I'll talk about in just a moment, that can respond to some of the scenes, depending on how far it is from Whitehorse. So the nurses are trained in ACLS, TNCC, scene response, advanced practice. We don't see a lot of pediatric cases. As I showed you, the population of pediatrics is just about 16% under 15. Which is great, but it also means that we have a difficult time keeping our competencies up in that area. So we've just recently added Broslow bags to our toolkit, and we are adding a simulator to help people keep their competencies up. This just depicts some of the remote scenes that we attend to. As I talked about the adventure tourism, some of the areas around Whitehorse have been voted the best mountain biking trails in the world. So we have a lot of mountain biking tourism as well. But that also means injuries very remotely, and so it's how do you access that? So the different services available to access remote scenes are Search and Rescue, Parks Canada, RCMP, EMS, and in terms of nursing, our nurses attend a limited radius outside the community because they still have to cover the community. The communities have rural health centers. This one is Haines Junction Health Center. And in the communities, we can do basic stabilization. Our nurses are not trained in intubation, but they can do King Airways, IV, IO access, basic cardiac monitoring. This particular health center participates in about 118 road transfers per year to Whitehorse, about an hour-and-a-half drive from Whitehorse. And what that means is that we either have Whitehorse EMS come out to the community, which means dispatch time plus an hour and a half, or we meet on the road and transfer at designated spots, or depending on stability of the patient, the team from the health center may go all the way into Whitehorse. So I talked a little bit about services in the community. It's similar to the other 3 territories with expanded scope of practice nurses. And in Yukon, what is different is that we do have EMS in almost every community. So whether it's first responders, basic paramedics, or advanced paramedics. The big thing is that we work as a team, and that's the only way that the system works well is because we all work together as a team. In terms of airport access, we have a helicopter response within 250-kilometer radius of Whitehorse. 4 out of the 14 communities have no access to medevacs after dark because of the topography and the terrain. And 2 out of 14 communities do not have airports that can accommodate medevac planes. Old Crow, which is the big red star at the top, has the longest response time, which is 3 hours to get to Whitehorse, or to get a medevac from Whitehorse. And Teslin has the shortest. If they're looking for an air ambulance out of Whitehorse, it's 1 hour and 30 minutes, which is actually the same as the driving time. So most often they will drive unless they need an advanced team. You've seen that local transport varies. People have talked about pickup trucks. This is Old Crow Health Center, and this is one of the vehicles that we have for use, as well as pickup trucks and vans. This shows one of the rural airstrips, and really because of all the road access that we have, there's no airport terminal. It's just a gravel strip just outside the community, and that's quite common. So Whitehorse General Hospital is our main referral center, and they have 55 beds. They have MRI, CT, surgery. They see about 33,000 ER visits every year. They do have adult ICU. They have obstetrics, surgery. All the deliveries are done in Whitehorse. The other facilities don't do deliveries, unless, of course, it's an emergency. They have medicine and non-critical pediatrics. We do have some resident specialists, and most of the other specialists travel up from the south and provide locum clinics. So our main referral centers are Vancouver and Edmonton. The flight time is about the same to each, and Edmonton has a little bit of a longer ground transport time, as we talked about. This just shows sort of a timeline from people to get from a community and then from Whitehorse on down south. So you're looking at a timeline from the time that the EMS and nurse respond to a call of being 2 to 8 hours to get to Whitehorse, depending on the challenges. So they may transport directly from the scene to Whitehorse. That's the minority. Most likely they're going to go back to the health center, assess and stabilize, and then transfer on to Whitehorse, either by ground, which is the usual, or by air. And air is going to be dependent on the darkness, the topography, the triage code, and the availability. And everybody's talked about the competing availabilities for resources. For air transport, it's about 1 hour dispatch to takeoff, and then it's community and flight time. So sometimes it's quicker to do it by ground, and so we meet Whitehorse EMS on the road and transfer over at that point. And if somebody is going from Whitehorse to Vancouver or Edmonton, the timeline is 4 to 6 hours to get a plane from Whitehorse, or sorry, from one of those centers to come up with a team. So in terms of the tertiary referrals, we've looked at some of the stats from the other territories, and in Yukon, we have less than a dozen neonatal and pediatric transfers south per year. And when you compare that to Nunavut's 500, it's significant. When I first came to Yukon after having worked for 10 years in Nunavut, my first question on orientation was, what's your RSV protocol? And somebody said, what's RSV? And I thought, where have I gone? And it was quite quickly made aware that there is huge differences here because we just don't have the pediatric population, and we don't have the same social determinants or conditions, and just whole different populations. So our tertiary referral is Vancouver or Edmonton, as I talked about. If it's pediatrics, there may be a specialized team that comes from the south, which is preferred. or if that's not available, then local paramedics, nurse, and a physician will make up a team. Obstetrics is made by a local team, and we use a neonatal transport team from Vancouver, and they will only come to Whitehorse, and the average wait for the team arrival can be 6 to 8 hours depending on conditions. And if there's weather delays, it could be up to 24 hours. So I looked at some of the CAPC recommended competencies and just some of the challenges we have around that for neonatal transports. So in terms of equipment, we don't have iStats readily available. We are looking at a program for expanding that. We don't have a high-frequency ventilator. In terms of training, we have difficulty accessing trainers and courses in the territory for some of the recommended courses. In terms of access to some of the required pharmacotherapeutics for transport, we don't have access to some of them, and one of the examples is surfactant. And then the experience with the low birth rates that we have compared to the other territories, we just don't see the volumes. We don't have the experience to be able to gain those competencies. This is just sort of a check-in and make sure everybody's still there. This is a picture from when I worked on a Coast Guard icebreaker. So just to summarize, I know other people have talked about cases. I just wanted to talk about quickly a case that I was involved in another territory. And this was to set the stage, it was in January. We were nearing the end of an RSV outbreak. We had medevaced at least 40 children in the last 3 weeks. And we had another medevac on the way for a 4-month-old with RSV. And we were told by the medevac company that this would be the last plane that we would be getting because there was a 3-day blizzard on the way and there was no hope of any planes during that time. The baby had SATs around 87 to 90% off O2, and we could only get them up to about 95% on O2. They weren't really responding to treatment that we were providing, so they needed to be hospitalized. When the plane was about 2 hours away, there was a major trauma in the community. 3 people were dead, and we had 2 injured adults with non-life-threatening injuries that required surgical intervention. We spoke with the crew, and they agreed that if we stabilized well, they could take them all. Again, it's the last plane we're going to have, but they needed a quick turnaround because the weather was going to be closing in. And so we were all prepared for this. And then one of the nurses turned to me and said, well, what else can go wrong? So, of course, we all know what else could go wrong. The mother of the baby, who was being medevaced, is 26 weeks pregnant, and she started to have contractions and went into preem labor. So we now have 4 patients and 1 plane, and no hope of any other planes for at least 3 days. So with a lot of triaging and stabilization, we sent the mom, the baby, and the worst of the injured, and then we kept the other injured and took shifts for 3 days till the weather lifted, providing care. On top of all that, we had a community that was traumatized, and we still had babies coming in with RSV that we were having to manage as well. So there are a lot of challenges in the north, and of course then once the blizzard stopped, it's the digging out, and that's a big dig out to get everything cleared so you can start getting planes in, getting transport to the airport, and getting people moving again. So that's my presentation. I just want to say thank you very much, and I guess we're open to questions for all of us.
All right, thank you, Sheila, and apologies for the time crunch, but we appreciate you still sharing all this great information with us. It really shows, the difference in patient demographics and epidemiology and logistics and everything across the 3 territories. It really is incredible, the differences. The one question that did come in for you, Sheila, was Sarah was asking, you commented on the difficulties in maintaining competence with the low patient numbers and that sort of thing. For neonates and for pediatric patients. She says, recognizing that it's difficult to maintain your own competencies in specialty transports, are there any formal programs to pass on that knowledge to the healthcare staff in your remote communities that you all service? So as far as translating that information from the central point in Whitehorse, for example, out to your rural communities, do you have a formal program for that?
Actually, we do. We introduced something about a year ago. And we have nursing practice coordinators who travel to all of our rural communities at least annually and provide a formal 2 days of training with the advanced skills and running mock scenarios and just running people through as a team in their own environment. And that's on top of the bringing people in for formal courses such as ENPC, PALS, those things, TNCC. And the reason we did this was because our teams are so small in the communities that we felt we really needed people to feel comfortable practicing in their community with their team, which could be the EMS, the nurse, maybe the clerk is helping, hang IVs or things like that. So we have implemented that program, and that's made a tremendous difference to people's comfort level.
All right. This question, I think, would be for Kara and maybe Dr. McDonald. Kara, I think it was you that presented the numbers, the differences between the Northwest Territories and Nunavut as far as the number of obstetric patients and the percentage of your transports that are obstetrics versus in Nunavut the number that are pediatric patients. Any insight as to why that difference is? Does it have anything to do with prenatal care in the Northwest Territories, in that high-risk patients are identified sooner and transported before they're born, versus in Nunavut where they wait longer until the patient is born before the issues are recognized, or is it just basically patient demographics in that there's more children in Nunavut?
Sure, I think that's a good question. I think it's multifactorial, as with most things. Certainly there are organized systems of transporting obstetrical patients to the regional hospitals later on in their pregnancy, so that they're actually at a hospital facility for the last 4 weeks of their pregnancy. However, that takes coordination with not only the patient and a willingness to leave their community, but also the ability for the community to have space for them, et cetera, et cetera. We do have midwifery programs both within Nunavut and the Northwest Territories. They're fantastic programs. They're very well organized, and the patients that participate in them do very well and stay in their communities and often have a wonderful experience. But we do have midwives in the Cambridge Bay facility, and we only have one and two. Just another community starting in the Northwest Territories, but nowhere in the Beaufort Delta do we have a midwife. So I think that I think those programs will certainly assist. I think one of the things that we find is that our long transport times from Nunavut is certainly a factor. So from the time someone starts having the symptoms of preterm labor to the fact that we can get an aircraft to them and get them out of their community, I believe a lot of those patients end up delivering their newborns somewhere along that lines, whereas within the Northwest Territories, there's a little bit quicker access. You can deliver both in the Inuvik Hospital as well as Stanton Regional. And then we're transporting those patients down if required, but also we're able to identify high-risk obstetrics and send them down to Edmonton perhaps a little bit more quickly. I think in terms of that's the obstetrical numbers, and there's a bit of a difference, but not huge. The really remarkable differences is in the pediatric population. So between the ages of 6 months to 2 years, RSV is still a huge issue in Nunavut, where there's a large percentage of Inuit. There's lots of the social determinants of health that they still struggle with. They're tiny kind of communities. They live very closely together. They're very community-oriented, and so they spend a lot of time with each other and in closed, environments because it's very, very cold outside. So they spend a lot of time in small areas with each other, and so the spread of RSV occurs really, really quickly. And within a matter of hours to days, we can find that there's an RSV outbreak in communities, and we're busy trying to transport everybody who has symptoms out so that we can manage, or by the time it gets, pretty rampant, we just try to get more resources to the community to assist. So we see that a lot more in Nunavut, in the Kitikmeot region, than we do in the Northwest Territories.
All right, thank you. Sheila, this question is for Sheila. How often, and Kara, you can certainly feel free to provide a response to this one as well. They're asking, how often do your teams meet to debrief/review transports, discuss what went well, what didn't, particularly when all of you have talked about the challenge, like the emotional impact on the healthcare practitioners of working in these difficult situations? How often do you have any kind of debrief session?
Sheila here. Any time that we've had a serious medevac, one that's been extremely challenging, there's almost automatically a debrief of the team, informal debrief of the team in the community immediately afterwards. If there's been significant challenges, then there may be a higher level debrief that, and we would also, if something's gone not the way we wanted it to, if there's been a bad outcome, then we certainly offer debriefing of critical incident stress as well to really support people, because it can be, the communities are so small and you're transporting your neighbor, you're transporting your niece, so you really have to be aware that we have to support people's mental health as well, just to keep them healthy and be part of the team. So it does happen very regularly.
Yeah, the same for us. We have a quality assurance program where we review 100% of our flights. It's a peer quality assurance review, as well as Sheila indicated, it's very easy to determine the flights that will have some lasting impact on our practitioners. And so whether from a review and knowledge perspective, a rounds perspective, or from a self-care perspective, we do have reviews of and debriefings of all of those types of cases. In fact, we've reached out to other flight teams as well and volunteer services that have come up to Yellowknife to help debrief very difficult cases, and it's nice to have other practitioners who work in air ambulance to be able to communicate with and connect with and realize that despite we're in the north and despite we're fixed versus rotor wing, we have the same challenges, and to work within that network is fantastic. So we've been very privileged to work with STARS and other teams like that.
Well, I think we have broken a record for the longest webinar. We've gone quite a bit over time, and I think maybe we should wrap it up, and maybe we'll hand it over to, I see from the list of people connected to the webinar, Dr. McDonald, I think, had to leave. But Penny, Sheila, and Kara, maybe just some final closing comments to wrap this session up with. Maybe we'll start with you, Penny.
Yeah, I would just like to thank everyone for participating. I think that the North is an enormously challenging part of the world to operate in and to provide service in, but it's also one of the most it's the most gratifying part of the world to offer service in as well, and so I just appreciate the opportunity to share some of that.
All right, thanks. And Kara?
Yeah, just a big thank you for being involved with both CAFC and the Knowledge Exchange Network. I think this is a fantastic group of folks who are working towards looking at, recommendations, competencies, standards, all of those things. I love to be involved with the team in any way, shape, or form to continue on with the work. I think the work is extremely important. And recognizing that there are diverse teams out there, that not all the teams originate in a tertiary care center, that we all, undoubtedly we take care of the most vulnerable population, and they deserve the level of care that everyone else receives in Canada. And so how do we best allow our practitioners to get the resources and the training that they need to be able to provide that care? So I'm very anxious to see what comes forward and very happy to participate in any way I can.
All right, thank you. And last but not least, Sheila.
Thank you. I think that the key is the passion of everybody involved came through, and that's what carries people through these challenging times, is the passion we have for the people and the work that we do and the difference that we make in those teams. And I just think that this work that your organization is doing is really key. And I really appreciate the opportunity to present the challenges that we do have, because there won't be a one-size-fits-all standard. It just can't be met in remote places. But certainly, setting those standards that we can meet, I think is very key to make sure that people have a good level of care, the best level of care that they actually can. And I think I noticed that there was one question about, what makes what are the best qualities in somebody doing this kind of work. And to me, it's being a team player, it's being adaptable, it's having that preparation that Penny talked about, but it's also being that patient advocate and having a strong voice for a patient who can't speak for themselves. And so I think that we're all on the same page in how we deliver care and what we have a passion for. So thanks.
All right, and thank you to all of you for sharing your expertise. I mean, without you guys sharing your experience, the rest of us don't have the opportunity to learn. So we really appreciate that. And Sheila, you mentioned your colleagues who didn't know what RSV was. You might be interested to know that the Canadian Pediatric Society just released an update to their RSV treatment guidelines. So you might want to share that with your community as well. But thanks again to everyone to all of you for coming and sharing your great experiences, and to the audience for hanging in with us. Most of the vast majority, all but a couple, were able to hang in all this time. So that's great. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great if you can watch live. As you can see, your questions and comments really help us enrich the discussion. But if you can't watch live, we do record, or if you can't stay on for the entirety of some of these longer ones, we do record the sessions, and you can always go back and catch up on any parts that you missed by searching for it on the Knowledge Exchange Network. We are off for the next couple of weeks, but we will be returning for the new season, I guess, of CAFC Presents on August 26th with a session called The Power of Touch and Infant Cuddling Programs. And this is an interesting session that came as a result of a partnership that CAFC has with Huggies Diapers. And through this initiative that we've to support cuddling programs in hospitals, we've been able to support the development of a white paper to highlight what the research tells us about the benefits of touch. And Dr. Marcia Campbell-Yo of the IWK Health Center will be joining us to present the research from their white paper that her team developed. And then we're going to hear from our colleagues from South Lake Regional Hospital in Newmarket, Ontario, and from CHEO, the Children's Hospital of Eastern Ontario in Ottawa, about their experiences using volunteer cuddler programs to leverage the benefits of touch that have been demonstrated in the research to support children and families. And following that, on September 2nd, we will hear about what roles can schools play in the pathway to youth mental health care. And for that session, we'll be hearing from one of the world's leading experts, and certainly a name that's familiar to many in the area of children's mental health, Dr. Stan Kuchar, and his colleague, Ms. Yifeng Wei, will be joining us to present a program that describes an evidence-based model that incorporates various components designed to more easily and effectively address youth mental health care needs. So that'll be certainly a great session for, as we heard, even today, one of the big challenges for our colleagues in the remote north, mental health certainly plays a role up there as it does across the country. So lots of other sessions in the calendar. You can find that information on the front page of the Knowledge Exchange Network. We do have other sessions coming up that we have some information there, so you can always go there and check anytime you want. Thanks for joining us today, and we hope to see you back here in a few weeks. All right, bye.